The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Welcome to Lymphcast, the gathering place for physicians, healthcare experts, and special guests. We dive into the world of lymphedema, venous disease, and other related disorders, exploring their impact on your daily life. So settle in, unwind, and join us as we uncover everything you need to know about lymphedema and related conditions on our engaging show Lymphcast.
Today's Lymphcast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Well, greetings and welcome to our Lymphcast show, episode 36 tonight. Thank you for being with us, whether you're on the podcast, listening only, or on YouTube. We are on every podcast platform out there. You can find us Google Podcasts, Apple Podcasts, Spotify, and just about everywhere else. We also want you to visit our website, lymphcastnetwork.com. Everything you need to know about this show is there. We also encourage your questions for the doctors. That address, hello@lymphcastnetwork.com. That's hello@lymphcastnetwork.com. Let's go ahead and meet our panel tonight from Arizona, Dr. Monica Glavitsky. Hello, Dr. Glavitsky. How are you?
Hello, everybody. Nice to be with the team and our guest. Looking forward to our discussion.
All right, very good. And from New Jersey, the founder of VitaSupport MD. We want you to visit that site, vitasupportmd.com. They make Vein Formula 1000, Lymphatic Formula 1000. Physician, surgeon, Dr. John A. Chubak. Hello, Dr. Chubak. How are you?
Hi, Paul. I'm doing well. Good to see you again.
You too. Dr. Chubak is also the creator of this show. I need to point that out. Dr. Glavitsky, I'll hand it back to you. Bring in our special guest, and off we go.
Absolutely. This is my privilege and pleasure to introduce to you our guest for today's Lymphcast. Professor Thomas Maldonado is endowed Schwartz-Buckley professor. He's from New York School of Medicine. He has extremely impressive bio, and I should probably mention a couple of things, couple of facts about Tom. So Tom was past president of Vascular and Endovascular Surgery Society, New York Vascular Surgery Society. He is a distinguished fellow of Society for Vascular Surgery, currently editor-in-chief of Vascular and Endovascular Surgery, and working in NYU Langone Medical Center. Of course, this is just a little brief something about Professor Maldonado. And this is my pleasure to turn to you and say hello and welcome on our program.
Well, thank you so much for the kind introduction, Monica. It's really nice to see you virtually here. You're in much warmer climate than I am, but it's nice in New York anyway at this time of year. It's nice to be here and look forward to our chat. So,
Tom, and I because we know each other for a long time, I allow myself to say Tom to you.
Of course.
And I was very happy that you accepted our invitation because, as you know, our program is oriented towards lymphedema, patient lymphedema problematic. And I might start by the very simple question. What is your approach here as a good specialist of lymphedema to the patient coming to you with leg swelling?
Right. Well, it's a good question. I should start by saying I'm a vascular endovascular surgeon. And what's interesting about my field is that when I first was a sort of a young buck deciding what to do in medical school and I wanted to be a surgeon, never in my wildest dreams did I think that I'd be taking care of people with leg swelling. That wasn't really what I signed up for, so to speak, when I had these dreams of being a vascular surgeon. But in fact, I think that it goes without saying that a large number of patients that we see in vascular surgery and vascular medicine are patients with leg swelling. The most obvious clinical scenario that comes to mind is DVT or blood clots or problems with the venous system, the venous part of the circulation that can lead to leg swelling. But what I've come to realize is that there's a whole spectrum of patients and pathologies that result in leg swelling. And I've really learned a lot, I'd say, in the last 15 years about leg swelling and all the different causes and the ways to treat them. So I guess, I'll start by saying that when I see a patient with leg swelling, I go from the general to the specific, and I really try to understand whether they have something systemic going on first and foremost. Whether they have some sort of either congestive heart failure or renal insufficiency or liver failure, or some of these sort of big bad diseases that can cause leg swelling, right? And fluid accumulation. So I guess I go at that first, and I try to understand whether they have that. And sometimes they have many things going on at once, but assuming that's not the case, I really try to hone it down to whether the problem is a primary lymphedema problem, which we all know can occur at birth, congenital, or can occur and present later in life in the late teens, early 20s, or later, or whether in fact it's something that's not necessarily related to the lymphatics primarily, but perhaps more related to the venous system. And my office has a vascular lab where we do non-invasive studies, and we do duplex studies, in particular ultrasounds. People talk about ultrasounds for the leg or the pelvis and the belly. And one of the important parts of what I do when I see a patient with leg swelling after I take a good history and examine them is try to understand what their venous circulation is like and whether there's a problem there, right?
Yeah, absolutely. And so, do you also perform some more sophisticated studies to, once you excluded all the general causes of edema, to precisely diagnose lymphedema?
I was saying that while I'm well aware that there are those who choose to sort of, obtain further diagnostic tests to determine whether someone has lymphatic insufficiency or obstruction, lymphedema, I tend not to be too liberal with obtaining lymphoscintigrams or things like that. I tend to look at the venous. Sometimes I will look at the pelvis with axial imaging to look, or also the extremity with MRI. Sometimes I will look for lymphedema with an MRI, and then of course the pelvis with axial imaging, MR or CT. But I'm really looking for things like mass effect, pelvic masses, tumors. I look at May-Thurner, speaking again about the venous circulation, whether there's compression of the iliac vein by the overlying artery. But the short answer, I suppose, Monica, is I'm not too liberal with tests for lymphedema, such as lymphoscintigrams and things like that. I don't know whether I should be. I guess that's an interesting question. I would ask you, do you think there's a lot of benefit? I find it a very interesting academic tool, but I'm not sure I always, maybe sometimes there is some benefit as far as satisfying the patient's curiosity, because many of these patients, as we know, I call them orphan patients, right? They're patients who have been shopping for doctors or therapists and really are sometimes resorting to chat rooms. Patients are very desperate for answers. And so I do think that maybe there is a role for some of those tests for that purpose, to give them some closure or some answers. But as far as clinical decision-making, I don't find a great utility for it.
Yeah, I understand. And actually, that's a very common approach, because as far as we could find in the literature, actually only around 2% of the patients with lymphedema have lymphoscintigraphy, despite the fact that everybody is, whenever you read about lymphedema, it is considered as a gold standard for diagnostic, but certainly not an easy one, and certainly difficult to obtain the good quality examination outside of really academic centers. Mayo Clinic, of course, is doing it, and so on.
And I think that those who do lymph node transfers or who do some sort of lymphatic surgery I know that there are colleagues I know who utilize that in that setting to sort of study the lymphatics. But no, I did very much go from the systemic and then right into the, assuming there's a thorough history and physical, I do look at the venous circulation and try to, because I think that really when we talk about lymphedema, traditionally, we talk about primary and secondary lymphedema, and the secondary lymphedema, we believe, is oftentimes cancer as a leading cause. But in fact, in my practice anyway, I see venous lymphedema or phlebo lymphedema as the far and away the most common cause of secondary lymphedema. And for that reason, I oftentimes am very, very thorough about looking at the venous system.
Yeah, you are absolutely right, actually. Oh, I'm sorry.
If I can point out, I thank you so much, and sorry I have some technical problem with the big computer, but thank God for the new of little iPhone, so I can see all of you. But because I am focusing on lymphatic disorders, I respectfully use the lymphoscintigraphy, not very liberally, but when I clinically assess that the patient is potential primary lymphedema patient, I do send them for lymphoscintigraphy because I want to know what is happening to the lymphatic system. Because accordingly, with the treatment, I can assess how much can I help. If the patient doesn't have any lymph nodes visible on lymphoscintigraphy, I may use the treatment modality much longer than as opposed to someone who has 50% of the lymph nodes in the inguinal area or high echelon lymph nodes. And yesterday, I just had this wonderful 21-year-old primary lymphedema patient who called me from Santa Barbara for, in his opinion, no apparent reason. He got bright red leg and so on. Well, he is a primary lymphedema, congenital lymphedema, and he is now hospitalized because he had beautiful fungal infection in between the toes and swelling because he's also a runner, and he had to be on IV antibiotics. With this kind of patients, I do want to see lymphoscintigraphy, and now we have further study of indocyanide green, where we don't do that, but I have centers where I can send them for indocyanide green if typically before lymph to vein anastomosis or any kind of surgical intervention. So I don't abuse or I don't do lymphoscintigraphy. I don't send patients for lymphoscintigraphy just for my satisfaction, academic satisfaction, or patients' curiosity. I think there is still lymphoscintigraphy is a gold standard for visualizing the lymphatic system. And true, first and foremost, we have to know about the venous system. Is there any potential problem and so on? But in terms of the lymphatic problem, we see, and I see far more lymphatic problems after surgeries, whether it's a primary lymphedema or secondary. Even today, I had an 80-year-old woman, and she said, I don't know, all the venous studies are normal, and the patient was sent to me for evaluation. Well, further history goes, she had total radical hysterectomy 5 years ago. She had endometrial, she had uterine cancer. And with that, I can see quite a few patients having problem with lymphatic insufficiency in lower extremities, whether one or both. And then I do use ultrasound, and I can visualize on the ultrasound what is happening to the lymphatics, to the subcutaneous tissue. And now lately, before I used to see a lot of upper extremity lymphedema after breast cancer and or lower extremity lymphedema after any type of surgical intervention for either cancer or surgical intervention. Now I see a lot of lymphedema patients. And we know that, again, I use the ultrasonography, and there is a difference in the findings of lymphedema patients and lymphedema. And in terms of the lymphoscintigraphy, lymphedema patients, and it was published, they do have dilatation of the lymph vessels, and they have increased lymph nodes, popliteal lymph nodes. We don't know why. We need to do more studies about that. But it was a wonderful presentation, Dr. Maldonado, when you said, yes, first and foremost, check the venous system and then address the lymphatic system.
Yeah, and I should add that actually, Tom, your observation is quite common as far as secondary lymphedema, not non-cancer related, because in the recent review that was stated very clearly that practically 80% of the non-cancer related lymphedemas are venous, so they are febrile lymphedemas.
Yeah,
right. Yes. Monica, while I have you there, I have right now a new patient, a beautiful 21-year-old, very active lymphedema, stage 2, type 4. May I put her on the lymphatic formula? What is the cutoff point? When can I start lymphatic formula on youngsters?
So she is
lymphedema,
yeah,
stage 2.
And what age?
21.
Oh yeah, no problem. Yeah.
Okay.
She is adult.
Yes. Okay.
Yeah. No.
So
I wanted to just circle back a little bit at lymphoscintigraphy, because I think it's an interesting conversation. But what are your thoughts, since you tend to be so liberal or use it certainly more than I do? And I think it's fair to say, especially with the indocyanine green, that it does depend where your resources are, right? If you don't have access to these centers, then it's a moot point. But these lymph scanners, like the Delphin lymph scanner, some of these portable, they're not assessing lymph flow per se, but they are assessing sort of edema or water content. How does that fit into your practice? I can ask Monica and Emily or John about this.
Emily.
Yes, because I use ultrasound, and when I see a new consultation and I assess whatever diagnosis is, and I use ultrasound, I don't need to go any further to do the Delphin study or anything else. I am well-versed on the findings, and then I am focusing on the treatment modalities. So I don't need to know how much edema or whatnot, because I see enough on the ultrasound study. And again, if I think or clinically assess that the patient is congenital lymphedema, whether it's a lymphedema tarda or even precox, I may suggest lymphoscintigraphy to assess the lymphatic system anatomy, because then accordingly I would know what do we expect and what would be the future of this patient, and in terms of treatment modalities and so on. So I use ultrasound, and I don't need to use, or I feel that the other modalities that are available, and we have plenty of modalities, Delphin and other studies, it's not going to add to my assessment, and in a way it's academic.
Yeah, I think that, there is a component of what patients want, right? So sometimes these tools are useful for surveillance or follow-up, and to see the effect or impact of therapy. We do volume displacement for the limb to see whether there's an improvement in edema on follow-up. We'll sometimes do that. We're doing that now currently in one of our clinical trials to look at because to look at limb girth by itself sometimes cannot be so accurate. We displace the volume for the entire limb, get a more precise measurement of and I think patients like that because they can determine how their therapy is helping them or not. you're right. There's also a question of cost, right? A lot of these things are not free, and there's a cost to the system. So that, and this goes back to my initial observation, which is sort of how I practice medicine in general, I should say, is that if it's not going to change my clinical practice, I generally try to avoid costly tests. The one that I'm guilty of, I should say, is axial imaging, because I have to say I'm pretty liberal about looking at the pelvis and the abdomen with CT or MR venogram. And I do it sometimes, I hate to admit, because I dread missing some tumor or malignancy or pelvic mass that can sometimes be occult. And then I also do it to look for compression, Mayther errors, things like that. Not so sure it's the most cost prudent or effective thing to do, but I am guilty of that.
Vein Formula 1000 and Lymphatic Formula 1000 from Vita Support MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
Well, I think you have your idea when you do this kind of examination, and certainly you're looking for something, and this is the most important, to have the benefit for the patient.
Yeah,
that's for sure.
Yeah, and I have discovered I have to tell you, I can think of at least 4 patients that I've been fortunate. Depends how you look at it, but I've been they haven't been fortunate to have the finding, but we've discovered some real findings on some of these axial images that we've never have known. So
yeah, I would just say that I'm listening very intently and enjoying the discussion, because Tom, I was actually on the hot seat recently with this very same question, and I'm glad to see that our answer is very much the same. I was guilty of the same lack of lymphoscintigraphy in my practice, but the only reason is for all of the same reasons, I think, which are that, generally speaking, the patients that I see, we wind up, as we like to say in medicine and surgery, the hoofbeats turn out to be horses much more frequently than they do to be zebras. So I see a lot of the same sort of pathology and etiology over and over. In my practice, it's largely phlebo lymphedema, and we can prove that with venous ultrasound and exam and so on and so forth. And we treat those patients and they get better. Or we see patients who have a clear, as Tom pointed out, we always begin every good medical interaction with a complete history and physical. And the history will tell us 90 to 95% of the story in most cases. And then the physical examination supports that. And then I think that the diagnostic imaging of any kind, whether it be ultrasonography, lymphoscintigraphy, axial scanning, et cetera, should really be reserved for situations where we feel that it's somehow going to inform or direct our treatment. If we're doing it purely from, again, an intellectual curiosity point of view, I don't think it really serves anyone, and it can be a great expense and can cause confusion for the patient, which is another aspect to the results of some of these tests, especially when they're not being done in places with high volume and reproducibility of results and interpretation and so on and so forth. So I've been very, very cautious and limited in my use of lymphoscintigraphy. And fortunately, I speak from my own practice, where I see lots and lots of patients with swollen limbs, lower extremity especially, each and every day. The zebras are quite rare. And it's in those circumstances where I'll go to axial scanning, more advanced imaging, and even invasive studies with IVIS and so on and so forth. In the old days, I used to depend a lot on Mel Rosenblatt in Connecticut, who was a good friend and obviously very forward-thinking in all of this. But fortunately, most of these things are things that we're seeing, and we're able to help the patients without having to go to extremes. Emily, I would ask you this question. In 100 patients who come to you with lymphedema, how many will you send for lymphoscintigraphy?
Well, it depends. 100 patients of lymphedema, or 100 patients of lipedema, or 100 patients of phlebolymphedema. Phlebolymphedema, I don't do lymphoscintigraphy at all. But from lymphedema, primary lymphedema, yes, I want to know what is happening to the lymphatic system. If someone has clear-cut secondary lymphedema because of some sort of either pelvic cancer, and I see quite a few now after prostatectomy, there is no need for me to know what is happening to the lymphatic system after prostatectomy or pelvic surgeries and so on. But fortunately, I am located in such an area where when I need refer the patient to someone, I do that. And about a week ago, I had a patient who had history of Merkel cell, and he was doing fine. And on clinical examination, there was small little speck of the slight erythema. So I was able to contact a colleague of mine who did the biopsy on the same day. And guess what? The Merkel cell is back. And so it's wonderful to practice with such a setting where I can have the liberty to refer the patient immediately and instead of waiting and so on, so on. And now, of course, he's going to be treated.
Let me ask you a different question, more specifically. Let's say 17-year-old girl comes to me, lymphedema precox, all of the sine qua non on physical examination, etc. Are you sending that patient for lymphoscintigraphy?
If she is not having any other issues other than swelling of the lower extremity, no.
Okay, good. I agree there. We're on the same page. Now, when will you send her?
Let me tell you, this young man who is now hospitalized with severe infection, and I, in my 30 years of practice, I have not seen such a bright red lower extremity swelling and so on. Finally, he's responding to IV antibiotics. I will send him for lymphoscintigraphy once he is done with his maybe next month or so, because I want to know what is happening to the lymphatic system.
So I have just a quick question that, forgive it's really just for my own edification, but how does it change your management? Like, I understand that you want to know, and it gives you, more information, and perhaps it's better patient care because you can communicate more effectively with the patient and tell them with more certainty and give them some. But from a practical standpoint, do you do anything differently based on the results of the lymphoscintigram?
He may be candidate for surgical intervention. If he doesn't have any lymph nodes, viable lymph nodes, then he may be a candidate for lymph node transfer.
All right, that makes a lot of sense. That's where I see its use, because I have some colleagues who do that surgery, and those are the situations where I see some real practical value to it. But it is an interesting thing that I just don't have a lot of experience with. So that's why I asked.
Yeah, agreed. Let's ask this question, because I think this is a very important question that we've kind of been mulling around on this program for a long time. We did have that wonderful gentleman, that young surgeon from Mayo, who was doing lymphovenous anastomosis and transfers and so forth. Remind me of his name, please, Monica. Do you recall?
Farhad.
Farhad, yeah?
Yeah, Farhad.
Okay. One of the things...
He's a plastic surgeon. And most of these interventions are now done by the plastic surgeons.
Doing microvascular. So I would put this out there for Tom. I would put it out there for Emily as well, because this is from my point of view. Now, I've been doing this more than 20 years, but it's an emerging area. This was not on my radar screen before, let's say, the last few years, quite frankly. This idea of lymphovenous anastomosis, lymph node transfer, et cetera. Essentially, everyone I've ever seen come across and referred to others in my sort of sphere, we've treated these people conservatively with all of the well-known treatments that we've discussed: compression therapy, hands-on therapy, MLD, dietary nutrition advice, et cetera, et cetera, et cetera. Talking about non-phlebial lymphedema patients. When should we, who are the proper candidates, Tom? Your colleagues are doing this surgery. Who are the patients, and Emily, who are the patients that I see in my office that I should really seriously consider for evaluation and referral to someone doing this kind of very, very advanced tertiary surgery?
Yeah. So I would invite you very soon to read the chapter written by the Anthony Forti from Mayo Clinic in Jacksonville, who devoted the whole chapter of handbook to the surgical treatment of lymphedema. And I think it's the complicated story with all this, that actually you have like the parallel world. You have those plastic surgeons that very often are contacted, like, for example, for the secondary lymphedema after the breast surgery or other kind of surgery, because it looks like evident issue of the damage of the lymphatic system. But that's truly, the crucial point here. Who should go for further evaluation, thinking about the lymphatic surgery?
Right. What are the indications? Should I send everyone? Or, I mean, we need to have, I think, a better set of indications to consider this. So, Tom, you're our guest, our honored guest today. So let me get your impression.
I mean, I don't have, we do have a dedicated plastic surgeon who does a lot of this. So I think that I often send them for evaluation. My anecdotal experience and opinion is this does not fare as well in the lower extremities as it does in the upper extremities with breast cancer. I think that especially in those patients with venous insufficiency or phlebial lymphedema, they oftentimes are not considered at all. In obese patients, I think it's not as effective. But again, this is my anecdotal experience based on our center and the triage that occurs with those plastic surgeons.
Okay, there is a statistics and article written about doing the surgical intervention on the patients like this. My young patient that I have in the hospital, where with the frequent infection, the incident of infections are being reduced by the surgical intervention, where either lymph to vein anastomosis or lymph node transfer. And I would then, once he's healed, I would send him to our teamwork for surgical intervention, for evaluation of surgical intervention.
Well, but I would say that for the listeners of this podcast, I would be a little bit wary about having the take-home message be that anyone with leg swelling should be considered for surgery. Not leg swelling. This young man
upper
extremity. Yeah.
No, he is lower extremity, primary lymphedema with multiple infections, and the last one is very severe.
Right. So there may be. I agree. There's definitely a place for it. But I just put that disclaimer in there because, as I said, a lot of these patients are very, lost and looking for answers. And I'm not always eager to steer them to that place. I reserve that for maybe the more advanced cases that have, for me anyway, not to steer the conversation away from surgery, but for me, my general philosophy about lymphedema is I treat it like cancer. I treat it. I try to intervene and manage it at the early stage and prevent fibrosis and more later, irreversible changes, right? And so, I think that surgery may be more important in the later stages, but most of my patients, I intervene early with a whole number of different approaches, compression, lymphatic drainage, pneumatic and non-pneumatic compression too now.
Take home a message would be, like in the early non-complicated stages, we should just have a very practical pragmatic approach. Just use the available treatment, such as compression therapy. What do you use?
So I have, traditionally work very closely with our physical therapists and do a lot of that MLD, but I am very much in favor of both pneumatic and now non-pneumatic compression, which is the latest player in the field here. The DaySpring, the Koya is the company. DaySpring is a device that actually can be used. It's portable, so it's used as the patient walks around, and it does not rely on air or pneumatic compression, but rather uses smart metal alloy flex frames, nitinol that constricts and relaxes based on electric current from a little battery pack worn on the waistband. And it really, in my mind, allows people this non-pneumatic device to exercise, right? To stay mobile, because I think that's an important thing that's sometimes missed. People talk about, well, you have to elevate your leg, but what happens is people are bedridden and they just stay there with their leg elevated and they don't really exercise. And so I really believe in exercise in general, but certainly for lymphedema and people with venous insufficiency, exercise, the calf pump is a really important part of therapy. And the problem with pneumatic devices is that they tether a patient to a wall, to an electrical outlet, and they can't exercise. And so my latest sort of game changer is the non-pneumatic device, this DaySpring device that people can use as they walk around. And again, I tend to try to prescribe these things and refer patients for physical therapy very early on before they reach these sort of irreversible fibrosis, et cetera.
Mm-hmm. Well, that's pointed out is a key where even in my practice, since I do only conservative management, I always recommend conservative management and keep the surgical opportunity as a last resort. Yeah. And Koya is fantastic tool where the patients can be active and moving around and having the stimulation on the lymphadematous limb.
Yeah. And there's been some studies with exercise and looking at lymphoscintigraphy and patients. These studies are out of Japan. I don't know how all these great studies come out of Japan in lymphatic space. Maybe you know as well. But they look at exercise before those who exercise and those who don't, and they see that they have much more stimulated lymphatic flow with exercise. And so I think it's doing patients a disservice to sort of hold them hostage to an electrical outlet. As important as that is, I do think that if they can exercise and stay active, it's very important.
You see, that talking about the result on the lymphoscintigraphy, we have also the study with the micronized purified flavonoid fraction, which improved significantly lymphoscintigraphy. That's something that you should think of for your patient because it's safe and might be useful treatment for them.
Yeah, no, I actually, speaking of my partner, Todd Berland, John, he had a whole show on that, on the flavonoids and venous health, and it was fascinating. He had Jose Almeida speak about this, and I think it's a really interesting field that, unfortunately, because there's no FDA sort of approval for this, it's I think not really sort of taking hold the way it should. But I think that there's a lot of patients. I have European and Latin American patients who really are coming back from their travels and tell me all about this. So,
well, we have it as a supplement in the US.
Yeah.
So
and it's really identical to the Daphlon 500 that Monica did all the research on for so many years in Europe for Servier. So we know that there's great data there. But I want to go back quickly, switch gears to something that I just think it's such a fascinating conversation, and we're working hard as a group, and that's the purpose of this podcast, to bring more and more experts and have these discussions and put our heads together. Like when Emily said she saves surgery as a last resort, there's something that's attractive about that statement, but on the other hand, there's something also that is potentially a pitfall about that statement, where I don't think surgery should be a last resort in the patient where surgery will really help that patient. In other words, I'm trying to figure out in my practice and through all of these discussions and all of the articles that are being written, where's the patient where I see it and I go, I'm going to send you to, Tom's colleague over at NYU. It's right across the bridge. It's, 30 minutes from here. And I really feel that he could help you with this operation. Why save something, it'll be like treating appendicitis conservatively when we have a good operation for it. How do we select those patients? That's what I'm trying to understand better as we have these conversations, because my fear is there are probably a lot of patients out there across the country who would benefit from a good operation, but they're being relegated to the conservative measure protocol because we don't have really a great way of differentiating who's who and what are the indications and who's more likely to do well and so forth. So that's one of the conundrums here that I find fascinating. The other question I would ask from a technical point of view, because I'm not familiar with this, Tom, do you know, or Emily, would you know, is lymphoscintigraphy being used as a post-operative study, and are the findings of lymphoscintigraphy significantly changed? Like we as myself, cardiovascular surgeon, we like to get completion angiograms and things like that. Do we have that kind of evidence?
So I can tell you that's the problem, right? There is no good completion angiogram for lymphovenous anastomosis. And so if you look at some of the papers that I've reviewed, in the journal I work closely with, that I'm an editor on, a lot of these techniques come from Japan and the Far East, and they have fantastic results, clinical results. But what's missing in their paper is exactly that, a good completion study, right? It's very difficult to get.
So I have a good news for you, because we are working with Peter, my husband, very closely with the lymphatic surgeon established now in Budapest. And he is doing exactly what you are saying. So after the lymphovenous anastomosis, he is doing the completion kind of angiogram with andosine green. And this is absolutely spectacular. This is, we just reviewed a couple of images that he sent to us. It's really beautiful. It's like the most beautiful example of the surgery, because it's so tiny. All these anastomosis are really of the hair.
Is that the day of surgery? Is that immediately the day of surgery, or is it like a month?
Yes, immediately. Like they are performing the suture.
Right. So he sees. I think I was referring to follow up, say a month later, how to study that, right? How to see whether that's still open or still.
Yeah.
That seems to be
to me the challenge, because
immediate patency that he's showing. After this microanastomosis, he's trying to prove patency at the time of the operation.
But actually, now it wasn't that
easy to see. I haven't seen pictures like that, so that's very promising. Yeah.
Yeah. I found it fascinating.
Yeah.
Right.
Plus, those andosine green photos are always beautiful.
Yeah.
But at the same time, we need follow-up after a few years. Not only get follow-up, but in the
Sure. So talking about the follow-up, so how you organize the follow-up with patients? How frequently you see those patients?
Well, the patient, when they have the lymph-to-vein anastomosis,
No, I'm not talking about surgery. I'm talking about the conservative treatment.
Oh,
So diagnose a patient with the lymphedema, and then what? He has a treatment or she has a treatment, and how often do you need to see those patients?
Well, in my practice, it depends. I'm looking not only at the limb, but I'm looking, where is the patient coming from? How long does it take for a patient to travel to get to the sentence? On the ideal setting, I see patients 2-3 times a week initially for about 5-6 sessions. And once
You're doing the lymphatic drainage session.
Yeah,
Yeah, sure.
Right. Lymphatic drainage, compression pump, therapeutic exercises, fitting patient with a compression sleeve or bandaging. It depends according to the patient's diagnostic need. And initially, I see the patients more frequently, and then gradually, once they are demonstrating an improvement, and that means the tissue consistency is softer. And again, initially, I do baseline ultrasound, and maybe a month later, I do repetition. I want to see, did we achieve anything not only by observation and measuring tape and so on. I want to see also what is happening in subcutaneous tissue when I repeat the ultrasound. And then I fit the patient to compression sleeve and or stocking, and I see patient once a month. And if they are maintaining, then I go to once every 3 months, and eventually I'd like to see them once every 6 months.
What about you?
Well, I see these patients, but I don't follow them in that way. I think I'd probably have to be a dedicated lymphedema therapist or specialist with a center. As a vascular surgeon, I am oftentimes a gatekeeper or someone who they see for another opinion, and I will direct them and I will give them my sort of recommendations if it's a primary lymphedema. If they are a venous lymphedema or a phlebital lymphedema, then oftentimes I'll operate on these patients, either ablation or iliac stenting, or there are sometimes DVT patients who require thrombectomy. There's a whole nother, group of patients, right, that we haven't talked about in as much detail. But so if they're not phlebital lymphedema or really venous and they're strictly primary lymphedema, then I will oftentimes refer them to my lymphedema specialist, a physical therapist who will watch them more closely. Inevitably, I develop a relationship with them on some level, and they do come back and see me, I would say maybe once a year, but I don't have much more to offer them as I'm not really the therapist, Yeah,
and I would just chime in to say that with my practice based mostly on venous disease and superficial venous disease with venous and phlebital lymphedema, those patients I see every 6 months to 1 year, and advising them that venous insufficiency is a chronic and progressive disease, and it should be followed and managed just as you would see a dentist, for example, because patients will sometimes disappear for years without thinking I've been treated and I'm, presumably cured because I went to this great vascular surgeon. He took care of me and he did these procedures, so I assume that I'm cured. And we try to educate patients in the practice that we have excellent management and treatment, but this is a non-curable chronic progressive disease, and some patients progress more rapidly than others. So we don't want them to go on to develop significant phlebital lymphedema in an interim period that is protracted, because it gets harder to manage those patients and keep them in their best vascular health if they disappear for years at a time. So 6 months to a year, I see those straightforward phlebital lymphedema patients with superficial venous disease. The other question I would, circling back, because Tom and I are surgeons, we get caught up on these things, and he's so knowledgeable in all of the literature as an editor and so forth. I've always found it so interesting. You ask about the Japanese studies with regard to these lymphatic studies and how fascinating and why they're always out of Japan. And I've always sort of wrestled with this conundrum. As general surgical residents, especially general surgeons, the Japanese have shown so many extraordinary, surgical tour de force cases on, especially oncologic cases, gastric cancer, colon cancer, et cetera, with these radical lymphadenectomies of the retroperitoneum and pelvis and so on and so forth. And you would never see anything about massive bilateral lower extremity lymphedema as a complication of these incredible operations, only improvement in survival rates. And we, of course, in the United States don't really link, generally speaking, for most malignancies, we don't link lymph node resection with increased survival. There are some exceptions, head and neck and so on, but generally we don't. But then you weigh that against the patient who has, let's say, breast cancer with a sentinel node biopsy where maybe 1 or 2 nodes are removed and they develop a lymphodematous extremity. and how I've never been able to reconcile, that in my.
Well, I don't think the gastric cancer patients live long enough, sadly, to really develop lymphedema, is my opinion. I mean, they may have good outcomes and they may have some, but these are older people who sadly probably don't have that life expectancy. I would imagine.
No, it's a good point. But the other question that remains a bit of a mystery, maybe Emily has an idea that maybe some of these patients have a hypoplastic sort of subclinical primary lymphedema to begin with. Why do some patients, unfortunately it's few now with advanced techniques like sentinel lymph node biopsy, where you're only taking 1 or 2 or maybe 3 nodes, as opposed to the days where Tom and I were training, where we were doing modified radical mastectomies, taking 20, 25 nodes. Why do some patients with such a minor node resection or biopsy sampling develop lymphedema of the upper extremity where most will not? Any thoughts on that?
Well, I think the Mayo doctors will put it that requires further research.
Yeah, I mean, the lymphatic system remains a bit of a mystery, which is why we're also fascinated. Absolutely. Really.
Paul, I don't know if we are understandable for a non-medical person. Do you have any question? Is everything clear for you?
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation. And at VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
Yeah, for the most part. In fact, I was thinking literally about 3 minutes ago, somehow, some way you've explained this very well for the medical community, but also for the non-medical community. I'm able to follow it. I don't understand it all, but I can follow it. I did have one question for Dr. Maldonado. I forgot the test you run. There's a certain test you prefer. What is that test called again?
Lymphoscintigraphy or
Okay.
The test.
The test you tend to rely on the most?
Ultrasound, duplex ultrasound, and the non-invasive vascular lab that we have in the office is sort of a first-line low-cost test that gives us a lot of information about the venous system in particular, yeah.
Okay. Now, you said when you run that test, you're looking for lymphedema, and everybody on the panel except for me understood exactly what you meant. But for the patient coming in layman's terms, what does that mean? What do you actually see? And by example, I've had doctors show me x-rays of broken legs. Well, I can see a broken leg when they point it out, or cancer, big black spot, I can see that. What does lymphedema look like when you're looking for it as a physician?
Well, I'm not sure we look for lymphedema on an ultrasound. The ultrasound's really more dedicated towards looking at the venous system. You can see interstitial, swelling or edema. Perhaps I might have been referring to MRI or CT, where you can sometimes see an MRI as sort of a honeycomb appearance in the soft tissues that's consistent with lymphedema. That can be a sort of diagnostic in some cases. I'm not sure I would order an MRI for that reason, but we can sometimes see signs of that if we look at the lower extremities. The the test maybe that now that it's coming back, maybe what you're referring to is the axial imaging, CT or MR, which is something I tend to get, not in all patients, but I tend to get it if I have an index of suspicion that there may be a pelvic component to the lymphatic problem.
Okay, and that's reasonably easy. Would it be reasonably easy for a non-medical person to see that through that testing once you pointed out what it is, or do you have to be trained to even see that far?
Well, it depends what you're looking for. If you're looking for May-Thurner's or some of these venous, compressive scenarios, you can see it. It's not so hard. Okay. So, if you have a big pelvic mass, that's also sometimes unfortunately quite obvious. But yeah.
Okay, I appreciate that. Monica, I'll hand it back to you.
Okay. So another question that we had is about what is actually the most important unmet need in the treatment for venous and lymphatic swelling?
Yeah, I mean, I think that unfortunately there's no cure, right? And I think that if you identified some sort of marker or prognostic tool that would allow us to identify patients very, very early and prevent them from developing lymphedema, that would be, a home run, right? Because right now we're playing catch up. When we have a patient, we're really managing them after the horse is out of the barn. And I think that an unmet need would be some sort of screening tool that would allow us to basically identify those patients who are going to develop rapid deterioration or who are going to have, poor outcome and intervene earlier. Again, the cancer analogy, if we can get to patients before they advance to stage 2, 3, you're going to have a better result. And I think the problem is patients who come in with a little bit of swelling or a little bit of venous hypertension may not take it as seriously. And in fact, those patients, as John say, might disappear for 3-4 years and come back with a big problem. So to me, the unmet need is early intervention, early detection, and trying to identify the patient that's going to rapidly deteriorate and get to them early. Sorry, go ahead.
Yeah, no. I just had the comment about the curability because actually, and for my reflection just recently, I was reading a lot about the medical history and so on. And my recent reflection is that there is really only few situations in medical field, whether medical or surgical, with the curable disease. How many hypertensive patients we have, we don't cure them. It's all palliative. Diabetic, the same.
Yeah, I mean, that's an interesting philosophy, right? If we all lived to be 500 years old, we'd all have aneurysms and varicose veins, right? So time is the ultimate enemy that always wins, right? And nothing's curable because of mother time, right?
Yeah.
So I understand. It's a good point. It's a good point. But something about lymphedema strikes me as particularly hopeless when it comes to.
But but on the other side, it's not hopeless. We have not.
I'm being facetious. It's not hopeless. I don't mean for our listeners. I don't mean that at all. I mean, it's not hopeless. But what I mean to say is that it is about. I believe strongly it's about early intervention and identifying patients early and getting to.
Sure. Yeah, sure. And this is the key. And in this regard, maybe we should do something about the post-surgery follow-up, because all these patients are actually exposed to possibility of the lymphedema. So they
Yeah, I mean, we didn't talk about orthopedic surgery, but that's an entire cohort of patients who, if we get to them early, we might do them a lot of good. And they come to you after they've had a knee replacement 2 years later. And maybe if they'd been in a program where they had been aggressively managed, this is the type of thing I think that is a little bit of an unmet need in my mind. And I think, going back to the non-pneumatic compression device, I think we are a little stagnant with pneumatic pumps in not allowing patients to exercise. So I think that's an unmet need that is now being met, I think, with this StaySpring device.
Yeah, the one thing I would say to as we're going to bring it to a close here, but one thing I give this little speech quite often on the show, Tom, but Monica brought out a great point. We, especially as surgeons, we wish every disease could be an appendectomy for appendicitis. because that's one of the real curative procedures. Fortunately, the appendix doesn't grow back, and you can really save a lot of lives that way, or with a cholecystectomy, removing the gallbladder. There are a few things that are very attractive to surgeons because they are curative in that way. I'm going to get in some trouble with my wife, our executive producer today, because we have been highly technical in our discussion and very medical. So for our physicians listening, and therapists and nurses and clinicians of all kinds, hopefully it's been very helpful for you. But we know that we have thousands of patients listening to this program who listen to every single episode. And I hope that it has been helpful for you as well, as you hear more terms and discussions. And also, as you hear as a patient, that even for we physicians who have expertise in this area, we don't have all the answers. We're still learning. We're still discussing these complicated problems. And the take home, I think, is once again that this problem of lymphedema is not one disease. It's many diseases. It's phlebo lymphedema. It's primary lymphedema. It's secondary lymphedema of many causes. It's lipedema, which may have a component of lymphedema, and then combinations, as we've talked about in the show before, phlebolymphopolipedema. It is a very complicated subject. We're learning more and more about it every single day. We're having these discussions, and we have great physicians and surgeons like Dr. Thomas Maldonado at NYU, who is there to evaluate people who think they may be a candidate for evaluation, who may have a swollen limb, upper or lower, one or more than one. And as Dr. Maldonado said, and this is the real point that I want to bring out in conclusion before we go around and say goodbye to everybody, this is not an appendectomy. This disease is not appendicitis. It's much more complicated. And what you're going to need for your best health care, no matter which of these diseases you have, is a team of experts. You may or may not need a surgeon. You may need, certainly, I think, a physical therapy and rehabilitation medical specialist, physiatrists like Dr. Eicher. You may need physical therapists. You may need, quite honestly, we've talked about this many times on the program, nutritionist, dietitian, psychologist. There are very intense emotional components of this disease. You may need a plastic surgeon for microsurgery. If you are suffering, if you're not finding the answers you need, keep searching and keep looking for experts in your area. Don't blame your doctors for their ignorance. They're not dismissing you because they don't care about you. Mostly you're being dismissed and put off, and as Dr. Maldonado put it so succinctly, sadly, but if you feel like an orphan patient, you're not alone, and it's not because your physicians don't care. It's generally because they don't know how to help you. But there is help, as we've all pointed out. It's not hopeless. There is help, but it's complicated and it's ongoing. I thought it was very nice when Dr. Eicher said she's seeing her patients ideally 2 to 3 times a week. It's that kind of disease where people need hands-on therapy, instruction, education, et cetera, et cetera. You don't have an easy disease. This isn't an easy problem, but there is hope. There is help. And keep fighting. And hopefully the new Lymphedema Treatment Act, which has been passed, is going to help to get people these devices, the new devices that the Koya device, for example, that Dr. Maldonado is referring to. So please keep tuning in, listening to the show, learning as we learn. And we wish you all the best and improvement with your healthcare. And we do feel for you because it's a complex and difficult problem. And with that, Paul, I'll hand it back to you to maybe say goodbye to everybody. And the time just always goes too fast.
All right. But, realistically, that's why they call it a practice. But also, every doctor I've ever met, including the 4 of you, you're always in the learning mode, aren't you? You didn't just, I went to medical school. That's it. I'll just show up at the office and go home. You're constantly learning, aren't you, John?
Well, yes, absolutely. Yeah. That's true. And it also, we've talked about this. Somebody like myself or Dr. Maldonado had many, many years of training, 4 years of college, 5 years of general surgery, research training, then subspecialty vascular surgery or cardiovascular surgery. So you come through this amazing training, the same for Dr. Eicher, Dr. Glowicki, with an immense body of knowledge, far-reaching body of knowledge. But knowledge now has become so vast and so deep that it explains why people like myself and Dr. Maldonado and others and Dr. Eicher have found themselves in such a tiny niche, such a tiny sliver of medicine, because to call yourself an expert in any one area now takes a lifetime of study and pursuit and experience and education. The idea of the old general surgeon, general practitioner is really sort of a dying art in some ways. And those people, in many cases, act as gatekeepers and triage people to direct their patients who have difficult problems to people like ourselves who have committed our lives to one tiny, tiny area of medicine so that we can feel confident at least that we're up to date on the latest treatment and therapies. So it's a big challenge.
Yeah, very well said. We want to thank everybody for listening and or watching. Visit our website, lymphcastnetwork.com. We're on every podcast platform out there, we believe. We're also on YouTube. And send in your questions to hello@lymphcastnetwork.com. Let's go around the table and thank everybody before we say goodnight. From Arizona, Dr. Monica Glowicki. Thank you, Dr. Glowicki, for everything today.
Thank you for having me here today. And thank you so much, Tom, for your participation in this program. And maybe I will turn to you to have the couple of last words, reflection from your side.
No, I think what John said really resonates, and I think that medicine and it's an everlasting, ongoing education, isn't it? And I think this, even tonight, I learned a lot, and I think just the more we talk about it, the more we learn, and the more we have to offer our patients. So I thank you for the opportunity to chat tonight. It was a lot of fun.
All right, thank you very much, Dr. Maldonado. From California, Dr. Emily Eicher. Thank you, Dr. Eicher, for everything.
Thank you. And thank you, Dr. Maldonado. It was fantastic discussion. And I would like to add, I want to say what my wonderful father used to say. He said, I'd love to know everything that I don't know. And on that, we have always much more room to learn more and more about everything.
That's right.
Thank you, Dr. Chubak. Thank you, Monica. Thank you, Dr. Maldonado. All the best, and we'll just have to do more studies and more research and get them out together for all our patients.
All right. Thank you very much. And the founder of this show, also the founder of VitaSupport MD, you can get there, vitasupportmd.com. Physician, surgeon from New Jersey, Dr. John A. Chubak. Thank you, Dr. Chubak, for everything.
Thank you, Paul. I'll leave you. Dr. Eicher reminded us of a great quote from her father, and I'll quote my old professor who was a neurosurgeon, Dr. Jonathan Lustgarten, who had a bit of a Yogi Berrism, who used to say, I'm not sure we understand everything we know about this. So that's an even more complex problem. We're working on it, though. We're working on it. So good night, everybody, and thank you so much for your participating. Tom, Dr. Maldonado, a pleasure to meet you, and thank you for your time. I know you've had a long day. We appreciate you taking part in this.
A lot of fun. Be safe, everyone. See you soon. Bye-bye.
Thank you again. It's been a Lymphcast, episode 36. Thank you. We'll see you next time for episode 37. Have a great night.